Okay, so last month, well, not last month, December now, we had the initial theory session. Maybe there'll be some of you on here who were on that session last time. It was a very good introduction to what we're going to be talking about today. However, I realize that a lot of you won't have been on that session. So what I'm going to do is have a quick canter through the basics and a bit of a refresher on what we talked about last time, just so you know where we're coming from. Then we'll look at an introduction to the military's favoured tool for discussing ethical dilemmas, which is the 4 quadrants approach. Then we're going to deconstruct that a little bit, have a look at the nuts and bolts of the various components, stick it all back together, and I'll give you a practical example of what the 4 quadrants approach looks like in use. And then we'll do a little bit of group work at the end. Okay, so there's my Tuppence Worth. I'll let you read that. As I sort of, for those who were here last time, I talked about a brief introduction to medical bioethics. Ethics is and always will be a difficult and vague topic to define and understand. It's just screaming out to be debated and discussed. There are no right or wrong answers in ethics. Those terms make ethicists shiver. And the more we talk about ethics, the more questions it generates than answers, it seems, especially amongst ethicists. But what we're trying to do here is just get nurses to do what we do best, which is to talk, in this case, about ethical issues. And that way, we're doing this short series of talks to hopefully arm you with the tools that you might need to structure effective ethical decisions with your teams, ethical discussions to make decisions with your teams. And we're using case-based learning backed up by a bit of theory, practical models, and some open discussion as well. Okay, medical ethics are not just for doctors, fact. Why should doctors have the only say? That's how it's been throughout history. I firmly believe myself that every action that we undertake in our nursing practice has an ethical and moral base. If you just have a think about it for a minute, our decisions in practice are influencing other people, and because the potential exists to alter another's life, any nursing practice is going to be by default a moral endeavor. And then every practical interaction we have with our patients, military or civilian, has the potential to alter their life as well, whether it's the smallest reassurance to the largest clinical interventions. And even Patricia Benner says, the guru herself, every patient encounter has the potential for an ethical implication at the personal, professional, or social level. And as I say, that applies to those of us in the military and in the NHS and beyond. And that's also supported by the literature, thankfully. So we'll take a quick look at medical bioethics, and here's where the engagement starts. Okay, what is the difference between morals and ethics? Crikey. Anyone want to open up their mic and offer a view on that?
We've got, I think Celia has commented in the chat box. She said healthcare ethics are all involved in but all involved in healthcare. Any advance if anyone want to raise their hand?
Okay.
Or if you feel more comfortable, pop it in the chat box. Morals and personal beliefs.
Yeah. Anyone want to speak? Just open your mic.
Hello.
Hi, Marion.
Oh, Marion.
Good afternoon. I think on my perception, morals refer more to like an individual's or a person's stance on a or belief on a particular issue, while ethic is like on more on societal or more on society, which is what is the acceptable norm in which 2 or more people agreed upon.
Okay, so, that's good. That's good. Yeah. So essentially, bringing it down to basics, morality is understanding the distinction between right and wrong and living according to that understanding. And that's from a number of viewpoints. And ethics is then the philosophy of how that morality guides individual and group behavior. So if you put it simply at its roots, ethics is basically a system of principles that help us to make decisions. And the two are very closely related. You can kind of look at it as morality being the foundation of ethics. So the next question then, how do we develop our own personal codes of ethics? Anybody? From a number of sources. Okay, we've got primary and secondary socialization for a start, parents, and then school and friends. we've got religion, we've got law, the culture, we've got society. It's an evolving process, and it's had to take account of changing attitudes and developments in society throughout history, as well as rapidly advancing technology. That can be demonstrated throughout history. We used to push people into church to pray away their illnesses. Nowadays, we have the medicine to heal them. Saints and superstition used to be the cure. Legislation repealing the laws in suicide, that was abolished in 1961. It was no longer illegal to commit suicide. Before that, it was seen as self-murder, and you wouldn't get a religious burial, and your family, they'd go after your family, the church. Society moves on, times move on, and morals and ethics moves along with them. We developed the NHS in 1948. Healthcare was not exactly ethical or just before that, because it tended to exclude the poorest in society. The NHS is great, free of point of care, accessible to all, based on the principle of the sickest treated before the richest. There's even public opinion shifting now towards euthanasia and assisted dying, so we might see legislative changes in future. They're constantly bombarding Parliament with bills to try and change that. But how do they apply to us, these ethics and rules, etc.? Well, they're distilled through 3 tiers, really. For those of us in the armed forces, 2 for everybody else who's on the call, or most other people on the call. Now, the first tier, ethics, is the broad system of principles which govern how we make the decisions, like we said, in daily life. And that's the base level of ethics for society, which is regulated by all those external factors. Medical ethics, the second tier, is much the same, but it applies really to how we make the least bad decisions in the context of patient care. And I say least bad because ethicists do tend to rock and quiver when you start to think about using words like good or correct, because that's going firm, you see. And the third tier is military medical ethics. And we're held to a higher standard of values and standards than general society through the Armed Forces Act, 24 hours a day, 7 days a week. And there's one prominent bioethicist says that we have to be held to a different tier of standards and a different tier of ethics, because the exigencies of battle pose unique challenges which are incomparable to the civilian context because of the scale of the threats to life, the unpredictability, and the levels of violence that we face. So there you go. Now we'll have a quick whiz through some relevant ethical theories. I don't want to take too long over this. The first one really is it's the basic level, really. It's the entry level for young children. It's how they start to learn their ethics and morals as they grow up in that primary and secondary socialization. Emotion versus reason. So emotion tends to overrule reason because they've not developed that capacity to rationalize their thoughts. So it's the gut instinct. It's the snatching the toys off the other child because it's my toy and I don't want to share. It's that gut instinct that drives those decisions they make in early life. As people continue to grow, deontology is the most widespread outlook to be found amongst most of Western peacetime medical practice. And that theory places duty at the heart of its ethical reasoning. It literally means, from the Greek, the science of duty. Now, medical staff under its terms are duty bound to preserve the life and well-being of their patients to the best of their abilities at all times. And the key thing is they must act to treat every person as an end and never as a means to an end. So you focus on the patients in front of you. It's a very, very strict theory. It doesn't really advocate deviating from it. So it's not ideal to stick to that on its own. Kant, who developed it, said that you must never act in such a way that if the act were to be universally adopted across society, it could become a norm. So it's got absolute rules like you must not lie, you must tell the truth. There's an absolute prohibition on cruelty to animals. I'm not saying that'll help you on the group work later on, but it might, that quote. That to be discovered in discussions later on. And well, pretty much it's lucky really that we're not held to one particular code of ethics and we're free to make our minds up about how we do things. So we can have a bit of a blend of different ethical theories, you might not even realize it, underpinning your decision processes. So the next one is consequentialism. Utilitarianism is the classic example for fans of the hot fuzz. Decisions are made for the greater good. And that is concerned not with having good intentions, but it's concerned with the consequences and producing good consequences, because this theory focuses on the consequences of a given action to decide its moral status as a right or a wrong thing to do. Jeremy Bentham, John Stuart Mill, they were the creators of this, really, or the major exponents of it. And they said they had a scientific basis for calculating what's right, and therefore what our ethical obligations must be. They reckoned they could calculate the greatest utility of a particular action to a particular society, and they called it the felicific calculus. I know it sounds like a Harry Potter spell, but it's not, I promise. Now, what's the major difficulty with trying to calculate pleasure, happiness, or minimizing pain? The major issue is that they're all grossly subjective terms. It makes them very difficult to quantify. If I asked 10 different people, hey, what makes you happy? I would get 10 different answers, guaranteed. So there you go. That's consequentialism. Again, not ideal on its own. Principlist ethics. This is the big four that you probably learned in nursing school or medical school, or whichever sort of secondary, tertiary education you went through. Now, they developed principlist ethics, these two characters called Beecham and Childress. Now, one was a utilitarian advocate and one was a deontology advocate. They came together not to decide what was different between the two schools of ethical thought, but to agree what they had in common. And then they developed this. And it's the big four pillars. It's autonomy, non-maleficence, so doing no harm, beneficence, actively doing good where possible, and justice. Now, the first three are linked with deontological theory, and the justice principle itself is concerned mostly with loyalty, fairness, and distributive justice, everyone getting their just deserts, everyone gets a fair crack of the whip. And they derived a number of rules from that as well, such as tell the truth, protect the privacy of others, and don't pass on to others information given to you in confidence, which, curiously enough, meets Caldecott and GDPR regulations. So that's lucky. But they've been sort of picked apart for being a bit abstract in their thought and having difficulty to apply it to real life ethics. So virtue ethics might help with that. That talks about people's character and the need for experience, and what does this decision say about me as a person? We had great fun talking about that last time on the thought experiment, about the trolley experiment. That's fantastic. If anybody wants to know more about the trolley problem, then please get in touch with me after. The email addresses and things are coming up. Now, the key thing is there's a theory of lifetime growth. You start off with emotion ruling reason, then you learn that there's consequences for actions, and then you can navigate through the ethics of life to ultimate virtue in the end and become the wise person or the wise practitioner. And that's based on experience. Okay. Right, that was a quick canter through. I hope I've not frazzled you too much. So we're going to move on to the 4 quadrants approach now. So this slide deck is actually available online through the University of Warwick Military Medical Ethics website. Anybody can use them. We ask only if you just sort of name checkers, if you're using them, keep the original slide at the start. That's great. It's in the open domain. It's great for introducing classes to the tool and maybe to present to others and do a workshop type exercise, which is what I normally do. Now, what are we talking about here? I've used the 4 quadrants approach myself, both on operational tours and at home in the NHS. I also teach this model to defence GPs, senior medical trainees, as well as consultants on the operational surgical training course. Now, while it's generally harder to get doctors to engage with it, with my experience, the nurses and the allied health professionals really seem to quite like it. Now, the great thing is you can do it anywhere. All you need is a piece of paper, a flip chart, or a whiteboard, or the back of a cigarette packet. And I've actually seen that happen once in Kosovo. I have seen that happen once. True story. So it can be done literally anywhere. All you need to do is just remember the process. It's important to let you know that it's not going to make the decision for you. I would call it more of an aid memoir to ensure that you're covering all the important points and don't forget something critical. It also forces you to take account of the patient's perspective and issues as well, which is good. So this slight modification we've got to our model just refers to the direction of travel through the quadrants and their positioning. It's a minor change made to make things seem a bit more logical and user-friendly. That's Professor Heather Draper's legacy, you might say. So it was originally developed from a Scandinavian model called the 4 topics approach in 1982, which assisted ethical decision-making in intensive care for palliative patients. Now, the caveat I've listed here means that it's clearly not the model for use in the middle of a cardiac arrest. You'll likely have your algorithms and policies already in place in which you're familiar with, because I guess the medical indications in that kind of situation are quite obvious. But it may be best employed once your patient's sort of stabilized a little bit and you've had time to breathe. Okay, here's your first look at the model. It's fairly simple, as you can see. I would advise maybe, well, I don't know if the guys are going to share this in the breakout rooms later, but if you take a picture of it on your phone or on your device, or take a note of bits and pieces, you'll be using it later on. It might come in useful if the guys can't get on the screen. There are 3 clear steps to follow. Within step 2 there, the quadrants in the middle, the arrows suggest the direction of flow through the 4 quadrants, and that's what gives the tool its name, clearly. The 4 quadrants can be loosely tied to the 4 core pillars of principlist ethics theory as well. So we see in quarter 1 is medical indications. The quadrants tied to beneficence and non-maleficence, as you can imagine. Quadrant 2 is patient preferences, tied to autonomy, obviously. Quadrant 3, quality of life, tied to beneficence, non-maleficence, and respect for autonomy. And the 4th one is the fudge-all, the contextual factors, and that's tied to justice, loyalty, and fairness, and anything else you can think of. Now, I know it says in quadrant 1 medical implications, but it should be indications. I think that's Professor Heather's dyslexia coming out. It's a typo, it's a diagram, and I can't change it, but it is medical indications, I promise you. So step 1, decide on the ethical moral issue. Step 2, walk your way through the quadrants. Step 3, come to the recommended moral action or ethical decision and then act on it. It's also important to note that the whole 4 quadrants don't have to be galloped through. If you can resolve the issue at quadrant 1 or 2 or 3, etc., then great. You don't need to push it any further. Just go straight to step 3. It's only if you can't resolve it that you have to push on through it. Okay. So step 1 then is about asking the right question. It's worth starting the discussion by agreeing the ethical issue which you're going to discuss. The 4 quadrants approach advocates a one-at-a-time approach. This is because there may be more than one dilemma worth discussing in a complex ethical situation, as the slide says. Ethicists enjoy being quite mystical and non-committal. I do hesitate to say vague and non-specific because that sounds quite bad in their deliberations. They don't like absolutes, usually, unless they're dyed-in-the-wool deontologists. So we like to use terms like ought and should, wise and unwise, and least bad instead of best or correct. So the phrase can I give ... takes on a different connotation when you say should I give, etc. I can give blood, for example, because it's within the art of the possible. I've got the blood, I have the kit to give it, I'm legally allowed to do so, but is it in the patient's or the state's best interests? Should I do it? What are my resources like? What's going on outside? Is there a major incident effect, etc., etc.? So in normative ethics, ought implies can principle. It is an independent ethical principle. The ought implies can principle states that logically an agent's got a moral obligation to perform a certain action, or in our case it might be procedure, only if it's possible for them to perform it. Therefore, if you can't do it because of scarce resources or personnel or relevant skills, or if it's against the law, then there doesn't exist any moral obligation to do so. And that uses a basic rule of logic called contraposition to turn the first principle round into the second. But the thing is, once you've identified the dilemma for discussion, you move on to step 2, which is your quadrants. Okay, that's generally the easy bit. Tells you what you can do. I'll just let you read the slide, to be honest with you, because it speaks for itself. We do know that doctors disagree over the best medical management of patients, and sometimes medical issues masquerade as ethical issues. And if you can overcome them, you can overcome them at this point, and that's it. Done. Decision made. Move to step 3. But if you can't, you can move on to quadrant 2. Oh, hang on. Yeah, the decision point on that there, it's not always clear. The medical indications, he's got a compound fracture of the femur. This needs to be fixed so that he doesn't have a fat embolus and he can walk again in future. You know, it's not always as clear cut as that. There are issues, you know, particularly in military and humanitarian deployments, and now in the NHS with COVID, etc. Rewriting the rule books, which complicate matters. They cause uncertainty. Scarce resource allocation, skill mix, best interest arguments, etc., etc. Maybe a patient's so badly injured, doctors just don't know where to start. And then things change. As we're no doubt aware, things are not always as they seem. Sometimes that'll sort the issue out for you. Patient's dead. Oh, no longer an ethical decision to be made. Conversely, it changes the question sometimes. The patient survives withdrawal of care, they've taken the tube out, and now they're up dancing a jig next to the bed. What do you do now? And at this point, you're probably best to loop back to stage 1 to reconsider the issues and decide which now is the most pressing issue. Quadrant 2, that can put an end to the matter. No, thank you. You're not doing anything more to me. Full stop. I want no further treatment. Happy days. That is the decision made. So we've got to respect refusal of consent by a patient. What about prior stated wishes to go no further? Advanced directives, DNARs? If you saw an unconscious patient with DNAR tattooed across their chest, would you take that as a competent advanced directive? Probably not. It's probably just their favorite band that you've never heard of. Going no further. Some things might be known about that. You assume that respect and refusal of consent assumes that the individual autonomy is trumping other concerns. Now, what about public health issues? What about the law, etc.? Look at COVID. Look at the recent situation with COVID legislation. You know, the push for public health protection. For instance, it's been illegal for you to decide that you don't want to wear a mask in shops and on trains because the state's trying to ensure that public health concerns trump your personal autonomy. Not that it's always called out or policed, as I've seen, particularly in Plymouth. Other things might not be known. You know, there's something to consider in your deliberations. If a GP gets called out to a care home overnight, has to make a decision, there's no next of kin. You know, it's going to be a discussion with the care home staff, isn't it? And what about minors, for example? Might be a different question. Parental wishes. Sometimes next of kin or parents might not be acting in the best interest of the patient who's a minor. If they were considered old enough or mature enough to be GILIC competent in the eyes of the law, most common decisions being about contraception, termination of pregnancy, etc., then the patient can make their own decisions without parental intervention. If not, and the parents provide decision making, are we to accept, for example, and just to use the classic trope, Jehovah's Witness parents blocking a life-saving blood transfusion? We use that in practically every ethics class we do. Or an organ transplant for their child. Sure, the hospital could apply for a court order to carry on treatment, and they often do. But it's, again, something to be considering. If you can't make your mind up on patient preferences, we'll assume in this case the patient's not able to express a preference for themselves, they're not competent to do so. You move on to quality of life. As it says, you only get there if you're unable to get a preference from a patient. What's the issues with judging quality of life, though? It's another subjective term. If I ask 10 of you what quality of life meant to you, I would get 10 different answers. If the patient's able to make the decision based on their own sound judgment, then no problem. Unless they express unreasonable preferences and think that maybe an inappropriate, unnecessary, or unavailable treatment they've heard about on the internet could improve their quality of life. It's one thing to competently refuse treatment and another thing to demand something which can't or won't be given or is not justified. Consider aspects of first do no harm and actively doing good where you can. It's likely to be informed by the medical indications, but people disagree on what gives life quality, as I said, if they're not making decisions for themselves, particularly. And there can also be a religious or a philosophical view on quality of life as well, and its relationship with other factors or principles, and that's going to take some careful discussion. If we can't make our mind up, we move to quadrant 4. Resource limitations. Yeah, you do what you can with what you've got. Cultural differences. We face this on a daily basis on many of our deployments in the military and sort of humanitarian terms. You've got to consider impact on others as well, but very rarely do people think about the medical team. The physical and compassion fatigue of the medical team's got to be taken into account, particularly if manpower resources are finite. I mean, who cares for the carers? That's one for a group like Captain Ann to discuss. So you see, I worked that in, I told you I would. Deployed military personnel, we're typically operating within military constraints. So we've got politically driven agendas, such as we've got an eligibility matrix that says who's available for treatment. We've got two-tiered care, we've got dual loyalty conflict. You know, it's a humanitarian disaster or a complex emergency. Are there different rules to play by, like triage rules, etc.? And in 2014, the military got sent to Sierra Leone. Oh my God, this is Ebola we're dealing with. The thing to note is quadrant 4 helps with transparency, but it's only meant to be for feeding in further information rather than using it as the sole slide and the sole balance to weigh things. Okay. And the important thing is at the end of that deliberation, step 3, make your decision and act on it. Okay, so we've decided we are going to do resuscitation and give life-saving drugs. Right, who wants a cup of tea? Oh, right, yeah, better give them. Right, so give the drugs, make the decision and act on it. That's the important point, okay. Otherwise, it's just a thought exercise. This is how our 4 quadrants approach looked in our deployed Bible, which we call the Clinical Guidelines for Operations, which was cunningly entitled Joint Services Publication 999. You see what they did there? And this is an example of it being used in anger. I went to Pakistan as part of Op Panika, and I went out there as the nurse educator to a military hospital in Rawalpindi for a few weeks. And this is the work slide that we did, the same sort of example I'm going to give to you. Dead easy to do on a flipboard. And this is one of the student nurses looking really cheerful. The room was absolutely packed. I got them to think about some ethical issues they'd encountered over lunch. They came back and we worked through one on the board and they absolutely loved it. They thought it was great. And they all wanted a certificate at the end as well. I haven't got certificates for you lot, by the way. So they do like certificates out in Pakistan. They love it. Okay, so if you're going to do this in a training context, literally do that. Draw the 4 quadrants on a flip chart or a whiteboard. Step 1 at the top. Step 3 in the middle, because that's central to what you're doing, and the 4 quadrants round about it. You know, it's important that you follow all the steps and don't do what doctors do and jump straight to step 2. Okay, so do you want this operation or what? Let's skip over things. So a final little quote. Some wise words from an old Greek dude, Aristotle. So lies the power in the decision maker in an ethical dilemma. Okay, it's within our power to act, but also not to act. Okay, any questions at this point?
Pop it in the chat box or raise your hand if you have any questions. No, lots of people taking notes, which is great to see.
That's good. In the group work sessions, you can have a look at the model on the screen. There's also a slide which has suggested questions that you ask in each quadrant based on your case. I don't think we're going to have time to do the worked up example that I've got, because otherwise that'll take us to about 1:45, and then we're not going to have enough time to feed back at the end. However, like I say, this slide deck is going to be online and available to people to look through. And I think the best thing for us to do possibly is just to get on with it, get into breakout rooms, have a look at a case, and then start talking through what you might be thinking of on the 4 quadrants approach. And then once we've finished that, we'll get a 60-second countdown to come back into the main room. And I'd like one identified speaker from each breakout room to quickly summarize the case that they've got. They're all based around scarce resource allocation, given the pertinence of that in the NHS at the minute. And then you can come back into the main room, present the case quickly, and then present the thought process that you went through using the model, whether you liked it or not, etc. Okay, how are we fixed for that? Everybody happy?
Sounds great.
Okay, great. So shall we have, let's take about 11 or 12 minutes in the breakout rooms, take us just past 1:45, and we'll have a case each. So Group Captain Lamb's going to have one room, Lucy's going to have another, and I'll have a third room. Okay.
Okay, just setting that up now. One sec, guys.
Thank you.
Thank you.
Thanks, Gabby. We did in our group, Anita very kindly volunteered to feedback, which is great. And we did kind of work through some of it. We didn't do it in depth, but we kind of went through the quadrants, didn't we?
Yeah, I mean, it's a whistle stop, because like I say, this is normally a half day or a whole day workshop, and I would be stood in front of a class with a whiteboard saying, right, here we go, let's talk about this. It's very hard to do. It's very compressed timeline. Lots of good ideas floating about though, guys. So well done in room 3.
Mm-hmm.
I would say in room 1, we didn't get to the point where we were able to choose somebody. So rather than put somebody on the spotlight, I'm happy to kind of give a flavour of some of the thoughts. But I thought the conversation was really actually quite broad, and brought in some really useful perspectives, such as, because it was about do you save a dog or do you save the doctor with limited resources? And the dog, being a military working dog, potentially could go and identify lots of human survivors of a catastrophic earthquake that a human wouldn't necessarily be able to detect. So, but then the doctor was somebody who was had long been the only doctor that had been functioning in that remote region of Nepal. So lots of really useful decisions and discussions coming in, and we didn't get to the point where we came to a conclusion, but I think it was there was quite a balance there of people thinking that the doctor was more important to maintain the longer term outputs for a very remote community, versus the military working dog that would be able to go and retrieve potentially many more survivors. So it was, did we, I think there was a shared approach of the sort of utilitarian approach to the deontological approach. And I think that's really where, to be fair, that's where we got to in that short amount of time.
Great discussion. Anita, are you happy to summarise our
Excellent.
case study and give some feedback to Alan and the rest of the group?
Well done, room 1.
We're room 2. I'm going to hand across to Anita. We did manage to, but we did a very kind of light touch over the quadrant, didn't we? We did manage to have some really good discussions. So over to you, Anita.
Okay, so we had a doctor that didn't have or had tested negative to the virus that everybody else had, but he did have cerebral malaria. And it was whether we moved him from the suspected isolation zone to the ITU area where there was a ventilator. He did need a ventilator, he was deteriorating, or whether we left him where he was. So we agreed that he needed a ventilator. There was obviously concerns about containment of the virus, although he didn't have it. So there was a view that he could potentially be moved and ventilated in the other area. The question then is, what happened around the cerebral malaria and what risk did that pose? We did think, could we keep him in the suspected isolation area and ventilate him there? But if anybody else needed the ventilator, it had come out of a clean area into an infected area, and then it was out of action. it does say that he was from a different area. So he was one of the, what do you call it? He was one of the team that was brought in to support.
One of the NGO doctors.
Yes, that's it. And so there was a question about were there cultural issues that were relevant that needed to be considered. Then about quality of life. What did everybody feel? Was it possible to contact his family advocates, etc., to find out what his wishes would be? What was the impact on colleagues? If any of the colleagues were treating him, how would they feel? Would their attentions be diverted to concentrate on him, who he was really ill? How did people feel themselves? You know, how would I want to be cared for in that situation? Would I want treatment? Wouldn't I? Etc. And how did those types of feelings impact on the care that he received, but also others received? And questions about how integrated the team was and dynamics in that respect.
Excellent. Very well summarised. Thank you.
Thanks, Anita.
Yeah.
Great.
Excellent. Okay, so well done, room 2. That was sounded very good. Room 3, I'll summarise the case, shall I? So we had a case of some personnel who'd come in to support an earthquake zone. There was lots of injured people, and there was a local care team that had been going non-stop 48 hours and were exhausted, so wanted some help. So we flew out a surgeon and a nurse from the military or NGO team to help them. As we got there, we took over immediately. Lots of work to do, lots of surgery. 36 hours of non-stop surgery later, our supplies are running very, very low. No antibiotics or anesthetics remain. Really, the only analgesics are morphine, a little bit of morphine, a little bit of paracetamol, and some non-steroidals. You know, the care team's exhausted, and we decide to suspend surgery. That's it, not do any more till we get more supplies and we have a bit of a rest. But we don't know how long it's going to take to resupply, because the supply chain's a little bit dodgy in that country. So it could take a couple of days, could be longer. And we can't really communicate terribly well because we're high up in the mountains as well. Now, one of the nurses that we've been working with begs us to look at her cousin. He's been waiting for 2 days. He's lost consciousness. He's got an open compound fracture of his leg, which is putrid, oozing pus. He is motionless, obviously being unconscious. Tachypneic, sweating, febrile, very pale, you know, a very sick young man. And she begs us to amputate his leg, to do something. So what do we do? Anybody care to jump in, talk about step 1? No? Okay. So we initially had a temptation to jump straight into the medical indications and bounce around the quadrants for a little bit. And then we went back to talk about what the most pertinent ethical issue was. We had some thought that, is there someone sicker than him that we could be seeing first? Is that the case to talk about? Who's the sickest? Who should we treat? Is that the main issue? There was a question of, the obvious question, do we operate or do we not on this individual? And then I thought perhaps that question could be a secondary one. If we decide to do an operation, is he the right person to operate on? Is he beyond hope? Is there someone sicker than him? Is there someone with a better prognosis than him? So we eventually settled on the ethical question for the sake of moving on to the quadrants, that the individual needed the operation. Then we went on to, we thought that's what needs to be discussed. Moved on to quadrant 1, medical indications. Lots of thoughts there. Anybody want to talk about the thoughts in quadrant 1, medical indications? So I had lots of people talking in room 3.
All gone very shy.
They've all gone very
Be
shy.
bold.
Right, okay, so the upshot is we bounced around the medical indications, and I interjected things like, okay, so if we don't have the operation, he'll definitely die. I realise that you're exhausted and all the rest of it, but it's that human compassion. It's that individual in front of you. You may or may not have people who are sicker. I'm not sure. But is it crueler to start treatment and then potentially have a lot of post-op complications, no pain relief, etc., etc.? Or is it kinder to not treat and let nature take its course in this case, because he's probably septic, he's probably headed down that path, and you don't really have the drugs to reverse that or halt it. We kind of bounced a little bit into quality of life, and also patient preferences was pretty easy because he wasn't able to express an opinion because he was unconscious. There was no indication of next of kin to be able to speak for him, or obviously there wouldn't be any advance directive or anything like that, because it's an emergency humanitarian situation. That's about as far as we got, really. I think we almost stopped it in medical indications to say, right, that's it. I've got no anesthetics properly. I've got no drugs. I'm just not operating on anyone, full stop. And that's perfectly valid. You could stop it right in quadrant 1. If the care team's not ready and they're not right, don't have the kit and equipment, I don't feel happy to proceed with this, then that's it. You stop at quadrant 1. And then you can start thinking about any other ethical issues that are remaining after that. So yeah, it's thought-provoking. I'm really sorry, it's a compressed timeline. Like I say, this is usually a half-day or a full-day workshop, and I am more than happy to come and deliver half-day workshops or whatever to anybody who wants to go through this in slower time with their teams, or to do it virtually or whatever. But it works better in person, to be honest, because then you have to talk.
It was great. I think we just had from the King's College group, just for your room, Alan,
yeah.
We discussed amputating with no anaesthetics, which would suggest we didn't have the ability to operate.
Yes.
Well, there you go. There was a feedback in the chat, so don't feel too.
Not the old tourniquet and a strip of leather, the old technique. That's it. Right, but anyway, no, it's good. There was a lot of interesting things being brought up. I think the key message is probably try and contain them in the appropriate quadrants as you're talking things through. All the slides are available there. If you want to practice that model in your own time, it's a great teaching workshop for a half-day session. It really is. And the only way that we're going to avoid getting tripped up by ethical decisions in the future as nurses is if we expose ourselves to the cases and the thinking beforehand.
Absolutely.
Because I don't know if you agree with me, but it's quite unethical to set these situations up to see what you would do in real life.
Never get it past research ethics.
Exactly.
No, I don't think so.
Rightio. So that's pretty much that's it from me, guys. Thank you very much.
Well, Alan, oh look, you're getting I've got to show you. Look at Valerie. Valerie's got it. If everyone looks at the camera at the screen, Valerie's got the whole team. We're going to be on our way right back. Thank you so much.
Thank you very much.
It's wonderful.
Whistle stop tour.
Yeah, just a huge thank you, Alan and Di, for joining us today. It's been a really, really interesting webinar, fascinating as always. Just to remind you, we've got another webinar this week on Thursday, and I've just had hot off the press that the Nursing Times will be coming to report on it. It's called In the Firing Line. It's actually based on feedback from our Nightingale Frontline sessions, which is our psychological safe spaces we're providing for nurses and midwives through the pandemic. And 3 of our facilitators are coming to share the main themes and how we can tackle those. So it's going to be a really great session on Thursday, just as it was today. So come and join us if you have a free time, but we will be recording it if you wanted to catch up later. And Valerie and the team, you're welcome to join if it's
thanks, guys. I'm sorry, I've not had a look at the chat because I've been presenting, but there's a couple of good comments on there. Just one for Celia, questioning whether military ethics are superior. The bar should be set high for all. Absolutely. I'm not saying in any way, shape or form military ethics are superior. All I'm saying is that we're held to a higher standard of values and standards in society versus the general public, because we are held subject to the Armed Forces Act 2006, which nobody else in the country is. So therefore, there's a lot more things we can be prosecuted for than you, basically. So we've got to watch our P's and Q's 24 hours a day, 7 days a week. But the ethics remain the same at the base, absolutely. Yeah.
I do think I love the whole structured approach, Alan. I do doff my cap to your guru-ness with the ethics, because it does bring people together to discuss these things in preparedness for when it actually happens. You're not then caught short. And as we all know with the COVID pandemic, that we have seen some very morally injurious experiences, and we know research tells us that that's what people hang on to, and that's what they cogitate over, and that's what then creates that longer term issue. So the caring for the carers, and again I push you back to the one on the the webinar on the 3rd of December, which you still can get as a link to this. So to enable you to have the tools to prepare you for very difficult decisions, but actually to be able to find meaning in those to help you in the longer term. So I will always be your Debbie McGee for these sessions.
Well, thank you very much, man. Thank you. We've all got that box locked up at the back of our heads, haven't we? That's it. The things that stay with us. Great. Thanks, guys, for coming so much. It's great to see you all.
You too, Diana, Alan, and we'll share the slides with you all. So please do, and we'll share the case studies. You can take it back to your team.
Absolutely,
really great discussions. Let's share
Excellent.
the learning more broadly. But thank you all. Take care. And
thanks very much.
Overrun slightly.
All right,
Bye-bye.
cheers.
Thank
Bye-bye.
you. Bye-bye.
I'll see you there, Sasha.
Thank you. Bye.